I think we're going to try to combine the Q&A session and the panel discussion a little bit. So gonna maybe aim on more of the ones that have a bit more of a discussion point in here. I think I like the first one, but I think Dr. Stock and Dr. Mullighan, I think probably be good to ask why patients should or shouldn't choose an immunotherapy.
Sure. I think that these days, if you have a BALL and you have not received, for example, in the frontline setting and you have relapse disease, there's absolutely no reason at all why not to choose an immunotherapy as your treatment if you're eligible. In other words, if the leukemia cells express the proper proteins on the surface. Immunotherapies are highly effective, even in the relapse setting. And therefore, I think that if you're in the relapse setting and you're eligible for one of these antibodies or immunotherapies, one should consider receiving it because of their high rate of efficacy. The goal in a relapse setting is to get patients to transplant, potentially curative transplant in general, and therefore using a treatment that has a high rate of success and hopefully not so much toxicity will be best. In terms of the frontline therapies, there are many trials now showing efficacy of combining immunotherapy with chemotherapy in the front line. That hasn't yet been shown with the CAR T cells, but even blinatumomab is actually approved in this setting. And therefore, if one is eligible, again, to receive an antibody in the frontline therapy, in general, I think the idea would be it's a very reasonable idea to participate in that kind of a treatment or clinical trial. I don't know if Charles, if you want anything to add.
No, I think you've covered it well, Wendy, and I think both of us made the point as well. But we've seen multiple trials now implementing different types of immunotherapy, particularly blinatumomab and inotuzumab options, right at initial treatment, induction. And so if you are enrolled in one of those trials, you will see those options offered to you. And we'll see this becoming increasingly mainstream, again, not just of relapsed refractory disease.
Thank you both. On that front, Ria has asked, how effective is immunotherapy, say if a patient has 70 to 80% blast?
Yeah, well, even in the relapse setting, these agents have high response rates, and both CAR T and inotuzumab in the relapse refractory setting have response rates of about 80 to 85%. So they're very, very effective. Blinatumomab is perhaps best used in the initial treatment of ALL when there's lower disease burden. But even it has a very high response rate of about 40% in the relapse setting when you have gross disease with up to 70 or 80% blast in the bone marrow.
Fantastic. And then again, another question from an anonymous sender is there a gene trial therapy of blinatumomab ongoing, or are there trials ongoing?
Yeah, I saw that. I mean, blinatumomab is not a gene therapy. Blinatumomab is, as we talked about, this bispecific T-cell engager. It's an antibody therapy. To my knowledge, there are no gene therapy trials ongoing in leukemia. Usually those trials are to try to introduce a gene that is missing in a disease, for example, like in sickle cell anemia. But blinatumomab, inotuzumab, the CAR T-cell therapies are a different approach. They are using targeted pieces of the immune system to attack very specifically the leukemia. And there are many trials ongoing with these agents, both in the relapse setting and in the front line.
Amazing. Thank you, Dr. Stock. Jess, I think one targeted towards you and maybe myself as well. How can patients better advocate for themselves? Coming at it from both perspectives, what do you think?
I think that the cliche of knowledge is power, and researching and informing yourself and or having a trusted loved one do so if you're in that acutely ill phase. Understanding what the standard of care is and what the emerging treatments are, and then being able to seek out second opinions to make sure that your treatment is right for you. Can allow you to communicate regularly with your treatment team and ask questions and share your experience. And I found that really being an active participant in treatment is not a passive experience, as much as we sort of sometimes want to disassociate and just go through the motions. It's important to understand that it is active and you do have a choice and you do have a say, and you should use your voice in your treatment. So
Yep.
I don't know if you have anything to add to that.
No, I fully agree. Using your voice and also being aware that, as much as we're there to be treated by doctors, we can also ask questions and take as much time as possible. I mean, I know that I've made quite a few people run late. I mean, I've waited for many appointments, so I think, it's only fair that I make other people wait for appointments as well. But just know that when you're in that room having conversations with healthcare providers, that time is yours and you should use it as wisely and effectively as possible. Also knowing that there's out of hours phone numbers and emails that you can use to ask for information around any form of treatment available. The internet sometimes is your friend. Always use it with care, I think. But there, as you've said, there is a wealth of information. Again, we have resources on the No ALL website. But I think, reading, asking questions, and never being afraid to voice an opinion, even if you think that it might not be correct at the time, just because if it's going to put you at ease or maybe lead to a discussion or a treatment or an outcome that you might not have had initially. Obviously, as we've all mentioned, there are many clinical trials ongoing, and different centers and different healthcare providers will probably put you down a different route depending on their best thoughts and feelings. And so if there are trials available, and you have the option to ask to be put on one, if the situation presents itself, then I had a clinical trial and it was quite good. Also, from a selfish point of view, that you are forwarding science if you're on a clinical trial as well. So always good to look out for no matter what. I think Charles and Wendy, in terms of patients becoming involved in their treatment decision-making and advocating for themselves, what would you respond the best to, or in what situations have you been led or influenced by patients?
Charles, would you like me to?
You first, Wendy, which your question
Okay.
regarding me.
Sure. Well, I think it's crucial. I so appreciate what Jess and you have said, James. I think it's crucial for the patients to be involved in their care, and you want them to be engaged, and you want them to be a partner in this whole process, because it is a journey, as you just heard from Jess. These are not short treatments often, and they are life-changing treatments, and therefore it's crucial to have a sound relationship, a trusting relationship, and an open relationship with your physician and care team. And as you both beautifully said, you need to advocate for yourself in the sense that there's no question too silly, and there's no question really too difficult to pose to a physician. And not that everybody always has the answer right off the bat, but we have to work together to try to come up with the best possible answers to those questions and possible plans for the patients.